Thank you everyone for joining. I'd like to start the Journal Club by acknowledging the traditional owner of the lands on which we are meeting today. So we all come from different parts of Australia and New Zealand. I'm on Gadigal land today. I pay my respect to the elders, past, present, and emerging, and acknowledge the deep connection to land, water, and sky. So welcome to the ANZSA Journal Clubs. This is the first one for 2025, and it's actually our 5th year running. So this is a forum for sarcoma experts from around Australia and New Zealand joined together to be able to discuss latest publication and talk about the latest research. We're using a new system today, so Teams, and if you registered once, you should get the invitation for all 5 sessions for this year. So the formats were 2 presentations. Each one will go for about 20 minutes, and we keep the questions right at the end of each presentation. Plus, but feel free to use the chat during the presentation to share your comments, questions. And obviously, this is recorded, and we will put up the recording on the ANZSA website as part of our education portal. So we'll start it. So today's Journal Club is hosted by the New Zealand team, Dr. Andy Johnstone, orthopedic surgeon. I'll let you introduce the 2 speakers today.
Thanks, Angela. So as Angela said, I'm Andy. I'm one of the orthopedic oncologists in Auckland as part of the North Island Sarcoma Service. And we've got 2 papers today from 2 of our senior trainees who are off to do orthopedic oncology fellowships. Caitlin's going to Birmingham and Fraser's going to Sydney. So you might get to catch up with him, Angela. No pressure, Fraser. So we picked a couple of slightly surgical bent papers. One of them is not strictly speaking purely sarcoma, but it is, I think, an important thing to spread the word on amongst non-cancer treating surgeons and also oncologists, so that there is an awareness of the different way of treating metastatic bone disease in their patients. And the second paper is a kind of novel paper that's come out of Birmingham and the Birmingham Orthopedic Oncology meeting, which was a novel meeting set up and happened at the start of 2024, where the idea being that there would be a series of meetings bringing together controversial issues in which there is no real evidence base for, to get a gathered expert opinion and to identify areas for further research and to give us guidelines for the current situation. So both of them are slightly surgical bent, but hopefully interesting. So without any further ado, I'll hand you over to Caitlin, who's sitting in the clinic at the Children's Hospital, and let her present the National Metastatic Bone Disease guidelines.
Hi, everyone. I'm Caitlin. Thank you so much for having me. This is quite an honor. As Mr. Johnson mentioned, I'm an orthopedic registrar here in the Auckland region, and I'll be discussing the metastatic bone disease guideline that we established last year. Not strictly sarcoma, but about sort of cancer health and guidelines and improvement of care, which is certainly relevant. So we all know that metastatic bone disease imposes a significant burden on our healthcare systems, and this is increasing. Certainly improvements.
You might want to share your screen, Caitlin, if you're.
Oh,
have you done?
I have.
Have you? I can't see it.
I have, but I can change that. It's all. Let me do that again. It is definitely sharing. Or it says sharing. Share. Metastatic bone disease. Share.
Can you see Angela? Is it just me?
See? So I'm really sorry.
Unshare and try again, Caitlin.
It says stop sharing now. And how about that? Is that working? No. Oh, now I can't hear you.
No, we can't see it. Do you want maybe unshare? No, okay. We can hear you, but not see the presentation.
Small? Large. It says stop sharing. I'm really sorry. There?
Maybe
No,
hop
nothing.
out and come back in again.
I'm so
Caitlin?
sorry.
I'll see if I've got it, Caitlin.
It definitely says that it's sharing on mine and tells me to stop. I can stop share, and then I can go back. Oh God, I'm so sorry.
If you would like to hop out and then come back in,
Yeah.
maybe that might help. Yep.
Yeah, I'm so sorry.
That's it.
Just unmute yourself. Yep.
Can you hear me? And is it sharing?
Yes, well done.
Both of them? This is so
Yeah.
embarrassing. All right. Can you see just the presentation or like my whole screen?
Yeah, so you have to hit presenter mode down the
Okay.
bottom, Caitlin, and that'll bring it up. There you go.
Is that good now?
Yeah, good.
Oh, amazing. All right. Well, once that's done. So yeah, as I was saying, we all kind of know that this is a significant burden on our healthcare system, and these patients are living much longer, mainly due to advancements in medical therapy. And despite having metastatic bone disease, these patients are still highly functional and often have long life expectancies, good prognoses. But once patients have bone mets, it can still cause major issues. And we as orthopedic surgeons play an important role in managing metastatic bone disease and making sure that we are avoiding adverse skeletal events or managing adverse skeletal events in the best way possible. There are a lot of factors to consider when managing metastatic bone disease, and it really does require a multidisciplinary effort to do this. And when that fails, we really risk inappropriate or ineffective care for these complex patients. So when we mean skeletal related events, this really just relates to severe pain, pathological fracture, cord compression or spinal instability. And really the goal is to ideally avoid a skeletal related event before they occur. And the reason for that is that it is quite well documented that patients who experience an SRE have much poorer outcomes. When it comes to patients, pathological fractures certainly associated with shorter life expectancy compared to patients who have a prophylactic fixation with similar lesions. Patients who sustain pathological fracture have a higher risk of depression and anxiety and fears around fracturing again. And we know that patients who undergo treatment for completed fractures have a higher risk of being discharged to healthcare facilities as opposed to their own home. And furthermore, any patient who has a pathological fracture, completed fracture, often has higher risks of complications, higher risk of revision surgery, and overall poor outcomes. And then on the other side of that is also the financial consequences. Prophylactic treatment is certainly vastly cheaper, and that's well documented mainly by US data. Hospital stays tend to be much longer for patients who have pathological fractures, which is clearly a resource, very finite resource. And when it comes to the type of treatment, there's good UK data to show that for things like endoprosthetic replacements, which seem like a very high upfront cost, it is actually much cheaper to do that and treat a patient with the appropriate surgery the first time, as opposed to ineffective non-operative treatment or the wrong type of operation that ends up needing to be revised. And obviously, for both of those things, those are really important for our patients and for the healthcare system as a whole. But it's really important to recognize that metastatic bone disease is very complex. It's a heterogeneous condition, and there are a lot of factors that need to be considered when formulating a management plan. And it's not just about avoiding that potential, skeletal related event. It's about treating it appropriately once it is recognized as a risk. And certainly disease factors like the type of primary, the medical adjuvant therapies that are available, the type of lesion, if it's lytic or blastic, and the location. The patient is obviously really critical. Would they tolerate a surgery? What is their life expectancy? What are their functional capacities and their goals? And then where that lesion is, and does it need an operation, and what is going to be the best operation based on those things above. And I just put up that picture because I thought it was a really sort of interesting example of what we mean by that. And it was appropriately identified that they had a lesion, and it was prophylactically fixed, but really with the wrong implant. It was a relatively young and functional patient with a oligometastatic renal cell carcinoma. And if some of those things were considered preoperatively, they probably would have, or maybe would have done a different surgery, which would have been in the form of an endoprosthesis. So I guess as all of these things kind of progress, we want to try and make surgery a bit more bespoke and really based on the patient and the collaboration with oncology and our medical colleagues to really give them the optimal outcomes. So there are some current guidelines available at the moment, and these are certainly what we have referenced and sort of used to base our guidelines on, specifically the British Orthopedic Oncology Group, and there's also some good guidelines from the European group. But what we've tried to do is take that information and then make it more relevant for the New Zealand healthcare system and our kind of unique population. And so overall, our the goal is really to standardize metastatic bone disease care within New Zealand and reduce some of the inequity that we've identified. So we've summarized the current recommended guidelines that are sort of international and within New Zealand and Australia. We've tried to really make a clear framework about identifying patients that might need surgery and what those what are the risk factors for patients, what to look out for, and when's the right time to refer. It outlines sort of site-specific surgical recommendations, which is probably more relevant to some of our orthopedic colleagues when they do get that phone call about a patient that's at risk of a fracture or has sustained a fracture, what's actually going to be the best treatment for them. And then also just really reinforces that multidisciplinary aspect to the care for these patients. And it was a really quite prestigious group of people that I got to work with and that were involved in this, multiple orthopedic surgeons, spine surgeons, oncologists, radiologists, nursing specialists that gave their input to create this document. And last year, the guidelines were introduced to the New Zealand Spine Society, the New Zealand Society for Oncology. We presented a poster there, and it was also presented at the most recent New Zealand Orthopedic Association annual scientific meeting. At the moment, the guidelines are really only available on the ANZSA website, and they aren't yet publicly released, but that's still something that we are working on and kind of the next stage of the guidelines so that everyone has access to them. But sort of in general, it's about a 55-page document, so it's quite big. And on the first few pages, we give a summary of the guidelines of about 20 points of what we consider kind of the key features of the guidelines and the things that are pretty critical for these patients. And then I've sort of just highlighted the ones that I thought were the most important. For us in New Zealand, we're hoping that all of our orthopedic services around the country have at least someone who is a lead clinician who kind of coordinates metastatic bone disease care, and they can be a liaison to, say, tertiary services at a higher center. But that we found that often makes it a lot easier if there's at least one or two people within a department, if they don't have a dedicated sarcoma unit, that they can be a liaison. and also making sure that referral pathways are really clear, so that GPs and medical colleagues know kind of who to talk to and when to talk to those orthopedic services. The reinforcement that not every bone lesion is a MET, and even patients who have had a history of malignancy, if they have a singular lesion or oligometastatic disease, that thinking about, is this potentially a separate primary? Do they need more formal workup, and do they need a referral to a dedicated sarcoma unit? The emphasis that any surgery that is done or any treatment that we offer from an orthopedic point of view should be lasting the patient's lifetime and should be giving them the best functional outcomes. And then also that all of our care, as always, should be patient-centered and really focusing on improving quality of life. So the guidelines really broadly, as mentioned, referral pathways, some of the skeletal-related event risk assessment tools, both for the appendicular skeleton and the spine, definition of the orthopedic role in metastatic bone disease, and really trying to make sure that we are, kind of holistic and multidisciplinary and, communicative in our management and liaising with our medical colleagues, again, to make the right surgical decisions. Adjuvant therapy, that's a very orthopedic summary of adjuvant therapy, but it really is around things like, treatment in relation to the perioperative period, and some guidelines around stopping and starting and medications or radiotherapy after surgical treatment. Perioperative management, these are patients that have some unique perioperative conditions, and just a good guideline of how to prepare patients for theater and some of the things to consider postoperatively as well. And then, as mentioned, sort of a site-specific guideline around management for different metastatic bone diseases. So we've made relatively straightforward flow diagrams about when to refer and who to refer to. And again, reminding people that if you don't know what the primary is, or if they have a solitary lesion, that getting a sarcoma input early is really critical, and doing a full local and systemic workup if necessary. And then also a spine referral pathway that kind of outlines exactly when we think that MRI should be done for the spine, and what lesions or what conditions are safer for non-operative management, and which ones we consider at least need a discussion with a spine surgeon. So as far as surgical management from the limbs, most of these can be managed in patients' local unit. It could be, at a regional hospital, but I guess the emphasis again is considering what implant you're using. Is that the right implant? Is it going to last that patient's lifetime? And if it's not, and they need something more aggressive or something more complex, then that needs to trigger a thought to referral onto a larger center. And then just some of those other special circumstances as mentioned. And then spine, the flow diagram really says it all. If you've got a patient who has a spine lesion that is concerning that it's unstable, or if they have neurological changes, they need a whole spine MRI, they need a discussion with a spine surgeon, and that's usually a pretty high level referral at that point. And once they are at the spine, at that tertiary unit, again, they still need a lot of multidisciplinary decision-making, a lot of perioperative considerations as well. And then the last one is the pelvis. A lot of METs occur in the pelvis, but actually a lot of them are stable and they can be managed with medical treatment alone. But the big exception to that is periacetabular lesions, particularly in the weight-bearing surface, which do have a risk of fracture and may need specialty treatment. But again, that could be if it's for a relatively small lesion and a low demand patient that might only need.
Let me just have this person drawing it down.
That might only need sort of cement, intralesional cementing, or if it's a young patient with a lot of bone loss and it's complex, it may need something like a complex reconstruction. But again, if you see that lesion, it should trigger that you need to have a discussion with an orthopedic surgeon. So overall, it's really just the summary is that these patients should have prompt evaluation, and that bone pain, particularly pain, atraumatic bone pain in a patient who has had a history of malignancy, should be worked up properly, and that consideration of a risk of an SRE should be there, ensuring that they have the appropriate staging, and then it's definitely a MET as opposed to potentially a new primary, ensuring that any decisions that are being made between services are, collaborative, and an ongoing discussion is made between the medical services and the surgical services so that the right treatment is offered. And then from our point of view, any operating that we do should be a durable construct that is allowing for weight bearing and is going to last the patient their entire lifespan. And then having a low threshold to try and identify those complex scenarios and refer when appropriate. And so overall, that's where they are right now. Our cancer control agency, TEAHO, is still, I think, finalizing their approval, and hopefully once that's done, they will be available for open online publication. And I think that's it.
Thank you, Caitlin. I got the email back from TEAHO last week, actually, so they've asked for some clarification on points. So that's always when you send somewhere for review. We'll have to do some tweaking before they put it up on their website, but hopefully it'll be live. And the New Zealand Orthopaedic Association are planning to put it out on in front of their firewall so that it's not members only. Questions about that piece of work, or thoughts around metastatic bone disease, or anything anybody would like to ask about it?
I can ask.
Yes, Stony Silence. I think it's a very popular. I've given the talk multiple times at Hip Society meetings. I'm doing it again in Greece at the European Hip Society this year. It's a real thing for orthopedic surgeons who are left to deal with the problem that they're not up to speed with current management of that particular type of malignancy. And the old, they've had breast cancer 15 years ago, it must be a breast met, and a solitary lesion can be dangerous. I think the Birmingham group showed 20% change in diagnoses, and a solitary lesion, even with a history of cancer. So the kind of it's trying to encourage people moving away from the oncologist referring on to the orthopod and letting the orthopod making a decision on his own or her own. It really should be a discussion about what's current in that particular field of oncology and what else can be done, and the real expectancies and goals of that patient. And we are being very aggressive in some of our oligometastatic disease and doing proper negative margin resections and solitary mets. So something to think about and cogitate over, and refer your local orthopods to if they are interested. Thanks very much, Caitlin. Was well presented on the technical pitches were out the way.
Can I ask a quick question? It's well done. It's a fantastic piece of work. Sounds like it's really needed for the orthopedic community. Into having this on your New Zealand front page. I was going to ask whether you would consider developing like a plain summary for consumer to understand when surgeons talk about different type of implants, or whether you feel that will be helpful.
I guess it's the current weighty document. The current weighty document is heavy, and the idea is that we will publish little. You saw and some of Caitlin's slides and flow diagrams there are sections of it that we can pull out with some specific spine bits, and we might make a much more succinct document once we get the whole thing through and approved. It is interesting for a consumer point of view, but from my personal experience, I see Peter's on there. Most patients who have been dealt with the metastatic bone card are in a little bit of a daze, and they're not. They want to know that you're going to do the best thing for them, and not necessarily interested particularly in the nuances of whether it's this type of implant or that type of implant. What's really important is engagement with what their goals are and what they want from what you're going to do. There's no point in doing a massive acetabular reconstruction of someone who's got 6 months left to live, because you're just stealing their time. So I think it is a good point, and putting things out there for consumer information is a good thing, because what it can do, and what we've seen in the sarcoma world, is that it may harm the patient to say, hey, look, rather than just nailing this, is there another way? You know, my oncologist says I've got a life expectancy of 5 years. Is that going to last me? So, that arms the patients to maybe ask the questions that make people on the other side of the table think about what they're suggesting.
Yeah, I'll make a comment there. Thanks, and Andrew and Caitlin, that was great. Yeah, I think I'm with Andy. Like, the patients are sort of like in a very difficult part of their life, as you know, Angela. I mean, you treat them with radiation as well, and largely they just want to be looked after. But getting them to understand that balance between, their health and how long they're going to survive, and the extent of their disease, and particularly for us, one of the most challenging things is just getting very contemporary survival information from medical oncology with the evolutions of new treatments. So, that sort of is challenging, really, because that sets the scene for the type of operation that you might sort of choose to do. It's all quite interesting. One of the other things, I might have missed it there, Caitlin, but, there's been a big vogue in the pelvis to move towards minimally invasive surgery, which is the sort of, we've been doing some of it in Brisbane, where for someone with a big acetabular defect, where like putting probes in and cooking the cancer and blowing up a balloon and putting cement and screws in using various Jude anterior and posterior column sort of techniques. And the patients literally come into hospital, can't walk, and they can walk out within a day or two. And it's great. It's got a small cut on their pelvis, and so there's a bit of it, and that sort of is all the stuff that's been championed by Francis Lee out of New York. And it's there's so much sort of going on, really, to try and improve the quality of care, but at the end of the day, the poor old patient still sort of like just struggling to deal with shell shock of what's happened to them a lot of the time.
Yeah, I mean, a very, very good point, Peter. One of the contributors on there is one of our interventional radiologists, Brendan Buckley, and we've just started an electrochemotherapy here in New Zealand, and that's going to have an effect on how we treat particularly some of our spinal disease. And so the document will need slightly updated again from that point of view, and the IR point of view, almost by the time we're ready to release it. So it might need some more tweaking as the electrochemotherapy comes online as well.
Yeah.
Thanks, Peter. Now, thank you again, Caitlin. Fraser, how are you going?
Yep, good, thank you. Sorry about the intro before.
That's all right. It turns out both of our orthopaedic registrars who are going off to do orthopaedic oncology fellowships are total technophobes. And poor Fraser shared his screen to show the background of how to join a Teams meeting. So that gives you an inclination of our technical hitches before. So Fraser is going to be, as I mentioned earlier, with you guys in Sydney for his fellowship in a year and a bit. He's going to present on the very recently published BOOM meeting, which is the Birmingham Orthopaedic Oncology meeting, which happened about a year ago, which dealt with two major controversial areas in our subspecialty: one, chondral lesions, and two, infection. And this paper is based on the chondral lesion discussion. So I'll hand over to Fraser to give a presentation on that, and then we can have a discussion at the end again.
Cool. I'll just try and share my screen. Does that look right?
Yep.
Yep.
Yeah, all good.
Thank you for allowing me to present. Sorry about my, I got my times mixed up for the journal club, sorry. So this paper is all about identifying the consensus and areas for future research in chondrosarcoma. So as Andy mentioned, this boom meeting was set up for January 2024. Essentially, it was designed to discuss topics that had inconsensus or limited evidence in the literature. So how this meeting ran is they invited 309 delegates from around the world with different representations, mostly from Europe and North America. And what they did is they designed a series of questions that sought to answer 21 key topics around chondrosarcomas. Overall, they had enough caseload from each country's experience to combine case numbers representing about 66 years of work in treating chondrosarcoma. And essentially, this was a large consensus meeting with experts in their field. As mentioned, they had two focuses, one on periparasitic joint infections and the other on oncologic reconstructions around chondrosarcoma. How they set up the meeting, so they set up 120 questions around 10 themes, and a month before the meeting was held in January, they sent it out to everyone involved in the meeting to try and create experts in their field and create consensus around these topics. And then they came together on the day with the answers of questionnaires, personal experience, and their local research to try and determine a consensus. And this is all publicly available on the Boom Consensus website. So I'll just go through each of the topics and highlight the relevant points that they found. So this consensus was looking at radiologic diagnosis of the cartilage tumours, and the question was whether they could accurately diagnose an aggressive versus a benign lesion without necessarily needing a biopsy. And essentially what they found was in the presence of soft tissue extension, cortical destruction, or perilesional edema, this had a high positive predictive value of differentiating a high grade from a low grade lesion. And the presence of soft tissue expansion and perilesional edema being predictive of high grade meant that you could start planning treatment without a biopsy necessarily. In terms of surveillance, this was one area that the in-between grades has no consensus for. So in terms of surveillance, they could stratify in between high and low risk based on the radiographic findings. And for those high risk patients, essentially at a minimum, they needed an MRI scan of the local site for recurrence and a CT, an X-ray of their chest to monitor for local recurrence. But what they couldn't come up with a consensus of is how to follow up and treat the in-between grade, which is the atypical cartilaginous tumors. So these are lesions that showed some degree of atypia on X-rays, so endosteal scalloping, a certain size of the lesion greater than expected, but no cortical breach. And so currently there's no protocol existing for follow-up of those ACTs. In terms of intraosseous chondrosarcoma, sorry, this is a busy slide, but essentially if a lesion has not penetrated the cortex, in other words, it's purely intraosseous, then the metastatic potential of these lesions is negligible. And then the other one, as previously mentioned from the consensus, biopsies are no more accurate than radiology at differentiating between benign and malignant central lesions. The use of biopsy was at a unit's discretion when planning for a wide resection, but ultimately were needed to determine whether that wide resection was needed or not. In terms of locally recurrent disease, this seems locally recurrent disease, it seems obvious, locally recurrent disease adversely impacts survival and patient outcomes with chondrosarcoma, regardless of the tumour grade. So those that recurred needed to be treated aggressively. In terms of the highest grade chondrosarcoma being the dedifferentiated chondrosarcomas, initially these tumours are known to have a very poor prognosis, but despite this, a quarter of these patients will still be alive at 5 years. And so with surgery being the main treatment, the surgery aims at achieving wide margins, whether that be through limb salvage or amputation. The other thing they found was that dedifferentiated chondrosarcomas are the only subtype of chondrosarcomas where there is some evidence for chemotherapy. All other grades of chondrosarcoma in the literature, there's very limited evidence to support the use of chemotherapy. And even with these dedifferentiated tumours, really the evidence is only there for the ones in the appendicular skeleton rather than the axial skeleton. So there's more work needed in this field. In surgical margins, this is one of the 2 areas out of the 21 consensus statements that didn't reach a consensus, is how much of a margin do you need to say that you're margin free and to reduce the risk of local recurrence. So the current consensus, which was agreed by about 70% of the group, suggested a minimum of 1 millimeter margin or more for a low-grade lesion in soft tissue or bone, and high-grade ideally more than 4 millimeters. And again, this only reached moderate consensus as how much margin is acceptable. In terms of those who did go on to have local recurrence, there's 2 strategies in managing this. Repeat aggressive wide local excision or close observation with the use of radiotherapy, especially for those areas that are deemed inoperable or high risk. In terms of those lesions that presented with pathologic fractures on their admission, it was hard to know whether these lesions always had a higher aggressiveness, but they tended to be more aggressive lesions. But the patients who presented with these pathologic fractures in their first diagnosis didn't necessarily have a poorer survival. And so really the goal for these patients is margins, and if limb salvage can be used to achieve wide margins, it's still safe to do so, not necessarily heading straight for an amputation. There wasn't a whole lot on pelvic chondrosarcomas. This was mainly focusing on the appendicular skeleton. Again, the consensus for the soft tissue or bony margins was unclear. But one thing that they were starting to look at is whether navigated or patient-specific jigs utilised to resect the bone were more accurate. And again, at this stage, needs more long-term research. There are multiple different adjuvant treatments available. Currently, surgical margin remains the most predictable in terms of local and disease-specific survival. There is some evidence that radiation therapy may be of benefit, especially in those with margin-positive tumour or in those areas that are unresectable around the pelvis. Again, there's very limited evidence for the use of chemotherapy in chondrosarcoma. The only evidence existing for dedifferentiated chondrosarcoma in the limb. So a bit all over the show there, sorry, but these are the sort of summary points. Radiographic surveillance is safe for the diagnosis of intraosseous sarcoma. So the Birmingham group have now set up a protocol for their, or an algorithm, I guess, for their diagnosis and management of these lesions without the use of biopsy. And they found in one of their tools, the radiographic aggressiveness score actually has higher sensitivity and specificity than biopsy for these lesions. I'll go through the back tip in a moment. Cartilaginous tumours with no cortical breach have negligible risk of metastasis. So the goal here being wide margins and tumour excision. Locally recurrent disease negatively affects patient outcomes, including disease-free survival. Locally recurrent disease should be treated aggressively as isolated, and the routine use of chemotherapy has a limited role in chondrosarcoma treatment, except for what had been mentioned. So this is the back-tip protocol designed by the Birmingham group, and essentially it's broken up into those radiographic findings that we look at. So looking at the size of the lesion and the largest dimension, usually being the longitudinal length, the presence of endosteal scalloping, and breach in the cortex, soft tissue destruction. And essentially they've created this algorithm they use for their follow-up now, which is essentially abolish the need for a biopsy. Areas for further work, so management of the atypical cartilaginous tumour group, or those in the axial skeleton around the pelvis. There's still very limited evidence as to how to treat these, wide local excision versus curettage or observation. And then defining surgical margins may never be answered, but areas for further work. Thank you.
Thanks, Fraser. So kind of whirlwind tour of the current thoughts from the orthopedic oncology community on the management of chondrosarcomas. I don't know what happens in your individual units. We stopped biopsying chondral lesions probably 2 years ago now, because we were falling into the trap of treating them on the radiology anyway. So we've stopped biopsying. It's led to a couple of things being taken out more aggressively than maybe they would have done if we'd known their nature beforehand. But again, we would have probably gone on the radiology and ended up in the same place. So I think this is a useful, very well put together piece of work as a first outing, and the contribution was massive from around the world, including many of the units in Australia and certainly our unit in New Zealand. Has anybody got any questions on all of that?
Hi, Andy, it's Joanna.
Hi, Joe.
Hey, so you guys obviously stopped biopsying some time ago. Is that what pretty much at this meeting people?
That's the consensus at the meeting.
Sort of cement that, and yeah, and
yeah, because we were always, even if we biopsied say you biopsied a pelvic lesion, which you were all looking at in the MDT saying this looks aggressive, and it came back as a grade 1 chondrosarcoma, we wouldn't have treated it as such, because we didn't believe the radiology, and so they got proper tumor operations, and so more and more, and I think this was coming through in all the tumor meetings, because anybody who's had to sit through an orthopedic oncology meeting, Peter's just organised one, and will tell you that there is always a big discussion and a big section on chondral lesions. And because we don't know how to deal with them consistently, and so this has been evolving for a few years actually, and we used to say chondral lesions were a truly MDT decision because it didn't almost matter what the biopsy showed. We were going to treat it based on radiology and our suspicion. So I think this is backing it up. We have aggressively resected a couple of things recently, as you know, that probably would have been more conservatively treated if we'd known what they were histologically, but we might not have trusted the biopsies anyway.
And I might have missed this at the start. Has the results of the meeting been published yet?
Yeah, this is published just this month.
Oh, lovely. Thank you.
Yeah. Any other questions? I will say very, very interestingly, and I'm sure Peter is in the same WhatsApp group, but 2 days after the meeting, I woke up at 5 to 26 WhatsApp messages from the BOOM Scientific Advisory Committee members as someone had put up a chondrosarcoma case, and there were almost 26 different approaches to how they were going to manage that. So despite the fact that everybody had agreed significant consensus on their treatment of lesions. We're all reverting back to our own prejudices as soon as they'd left the meeting. So there's a long way to go on it, but I think it's a valiant start.
It's Peter Grimmerson. Can I just make 2 quick comments?
Yeah, of course, Peter.
Just in terms of drug treatment, I agree that for conventional chondrosarcoma, there's no proven treatment. We're doing some trials in Sydney at Lifehouse, one of IDH inhibitors for those with IDH mutations, and one of a death receptor 5 agonist, which looks promising but has liver toxicity. But that's certainly, I guess, beyond orthopedics, but a big unmet need. I agree with D. diff chondrosarcoma. We sometimes use chemotherapy analogous to osteosarcoma, but just also to remind people for mesenchymal chondrosarcoma that they can respond to Ewing's-like regimens, and we might consider that in the adjuvant setting as well. But certainly a big deficit in terms of drug treatments for conventional chondrosarcoma.
There was maybe 2 years ago, a great presentation at ANZSA from an Italian group looking at immunotherapy and D. diff chondrosarc and alveolar soft part were the two, which are 2 very troublesome subtypes. I don't know if that's gone anywhere. I haven't heard anything else about it since.
Yeah, that's a good point. There was a phase 1 study only in abstract form combining immunotherapy with a tyrosine kinase inhibitor, which showed some promise in D. diff chondrosarcoma. We published a case report of a patient who had a non-sustained benefit. So probably immunotherapy by itself, not great, but in combination with a tyrosine kinase inhibitor may have some limited benefit. And as you say, alveolar soft part sarcoma immunotherapy certainly is quite useful.
Thanks, Peter. Any other questions? Thanks very much. I'll hand back to Angela.
Right. Okay. Thank you. Thanks, Caitlin and Fraser, for picking these 2 guidelines for presentation, your preparation, and Andy for hosting the journal club today. So our next one is on the 30th of April. It's going to be hosted by Peter McCallum in Melbourne. So hope you can all join us. Otherwise, we'll finish the journal club early, and you all have an enjoyable evening. Thank you.
Thank you very much.
Yeah.
Thanks, everyone. See you.